one and all, and welcome to the second session, and we'll be starting exactly in next 5 minutes. So I would just like to acknowledge the presence of our speakers. We have Dr. Hina Mubarak. Good afternoon, ma'am. Dr. Hina.
Good afternoon. Yeah, good
Dr.
afternoon,
Hina,
sir.
will you be able to turn on your video, please?
Yes, sir.
Dr. Hina, would you like to check your presentation so you can share your screen so we can technically be perfect before we start?
Okay, sir. I'm sharing it.
Up next, we have Dr. Mridul Kumar Sahani. Dr. Mridul.
Yeah, I am here, Dr. M. K. Sahni.
Yes, sir. Dr. Hina, you can share your screen so we can check. It's just a technical check before we start the event. We have time. All right, Doctor. You can now stop sharing. Dr. Hina, thank you. Dr. Mridul, would you be able to share your screen now?
Okay.
Yeah, Dr. Hina, you can stop sharing. We can see your screen. After Dr. Mridul, we'll request Dr. Seema Mahesh to be ready with the presentation.
Yeah.
Sir, we can, we can see your screen now. You can stop sharing, Dr. Mridul. Thank you. Right. Dr. Seema Mahesh, you can also check now. You can share your screen.
Okay.
Yes, ma'am, we can see your screen. Thank you so much. Dr. Surbi Jain, would you like to share your screen? Let's check it, please. Dr. Surbi Jain, if you can. All right, thank you, Dr. Surbi Jain. We have Dr. Amit with us. Dr. Amit, would you like to share your screen? Dr. Surbi, you can stop sharing, please. Thank you. Your slides are visible, ma'am. You can stop sharing the screen now. Dr. Amit, would you like to share your screen? Okay, I think Dr. Amit is not here with us.
Dr. Sabina is there instead of Dr. Amit.
All right, so Dr. Sabina, would you like to share your screen, please? Thank you, Dr. Shelly.
Thanks.
I think even she,
Dr. Sabina, she joined.
Sabiha, Dr. Sabiha Naz.
Yeah, Dr. Sabiha Naz. Okay.
Dr. Sabiha, would you please share your screen? Let's check. And you need to adjust your camera also, ma'am. We are not able to see you completely. If you're using a laptop, you can just take the shutter a little bit lower. And after Dr. Sabiha, we would request Dr. Dilip to be ready. Yeah, Dr. Sabiha, you're visible now. Would you like to say a good afternoon?
Good afternoon to everyone.
Yeah, you're audible now. Thank you so much.
One more thing, one second.
Yeah.
Dr. Sabiha, this paper is from Dr. Amit and you are presenting on his behalf, right?
Ma'am, I was the co-author of this.
You are the co-author of the paper.
Since Dr. Amit Sahani is on, I'm the co-author of this paper.
Okay, okay. Fine.
Yeah, Dr. Sabiha, would you please share your screen? Are you able to do that?
Yes, sir. Sir, is my screen visible?
No, it's not visible yet. Okay, till the time you are able to sort out the technicalities, Dr. Dilip, would you be able to share your screen now?
Good afternoon. Am I audible?
Yeah, you are
Sir?
audible loud and clear, sir. Just share your screen.
Yeah, sure, sure. Visible?
Visible, sir. 1 second. Yeah, visible, sir. You can
Okay.
stop sharing now.
Okay, thank you.
Yeah, Dr. Sabiha, are you able to sort it out? What you need to do is you have to open your presentation first. Then you have to go on the green icon which reads share screen, and then you'll get different options from which you can select your screen, the slideshow which you've opened and kept.
So is it
Yes,
visible now?
yes, it is visible now. So you remember the path now. So so when your turn comes up, we are perfectly on time. Thank you so much. You can stop sharing it now. Dr. Nishant. Good afternoon, sir. Dr.
Good
Nishant.
afternoon, very good afternoon.
Dr. Nishant, would you be able to share your screen now, please?
Just a second, sure.
Right. Ladies and gentlemen, we are just 1 minute away to begin our next session. Yes, Dr. Nishant, I think your screen will be visible any moment now.
Thank you. Thank you.
Dr. Brunalika Dixit, would you please share your screen? Dr. Nishant, you can stop sharing. All right. So, ladies and gentlemen, most of us, we have checked our technical stuff. We are all ready. So let me welcome everybody on the second day of LMHI 2021, the Global Colloquium. I am your MC and Time Manager, Himay Lakhani. I would now like to welcome our moderators, Dr. Shaili Arora. Good afternoon, ma'am, and a warm welcome to you. I would also
Good afternoon.
welcome our second moderator, Dr. Nirmal Yadav. Dr. Nirmal, good afternoon and welcome. And for all our foreign delegates, namaste and a warm welcome to everybody. I would now also like to acknowledge the presence of our session coordinators. We have Dr. Radhika Kataria and Dr. Ritika Nagpal. Thank you so much for all your support, and they are here going to be with us. Now, I would like to hand over the virtual dais to Dr. Shaili, and she would introduce the chairpersons and the speakers followed that. Thank you. Namaste.
Thank you, Mr. Heme. Good afternoon, India time. I'm Dr. Shelley, and my co-host, Dr. Nirmal, will be moderating the session. I welcome you all, dear guests. Dr. Nirmal, can you take over, please?
Yeah, thank you, Dr. Shelley. My greetings to one and all. I welcome you all in this session of LMHI Global Colloquium 2021. The theme of our session today is Case Reports, Observational, Pragmatic, and Randomized Control Trials, with the sub-theme as Case or Cohort Studies of Miscellaneous Subjects. To chair this session, I would like to welcome our esteemed guests, Dr. Birendra Sharma and Dr. Philippa Febert. Dr. Birendra Sharma is working as the Deputy Director of Directorate of Ayush. He has been one of the main pillars of our homeopathic department and has been dedicated to the upliftment of our department for last several decades. I welcome you, sir. Dr. Philippa Febert, she is a research fellow at the St. Mary's University, where she teaches about chronic disease management, and she's also currently managing a trial of kefir for ADHD. I welcome you, ma'am. So now, without a further ado, I would like to begin our session for today. And I'd like to call upon the first speaker, Dr. Hina Mubarak, who is an MD student from Dr. Emil Dhavle Memorial Institute, and she'll be presenting her observational study on exploring the action of LM potency in bronchial asthma. The stage is all yours, Dr. Hema. Sorry, Dr. Hina.
Yes, ma'am. Is it visible to all?
Yes, ma'am, it's visible. Make it full screen.
Dr. Hina, we can see the screen.
Okay. So I will start. Good evening to all.
Make it
I,
full.
Dr. Hina Mubarak, I'm going to, hello.
Make
Yes.
it full screen. Full screen.
So it's full screen. Is it visible now?
Ma'am, it is visible, but you can start the PowerPoint presentation so it would come on the full screen.
Like this?
No.
You can run the slideshow.
Okay, no problem. You can go ahead.
Okay. So I will start it now. My topic is exploring the action of LM potency in bronchial asthma. It was an uncontrolled experimental study. It has been conducted in Dr. M.L. Davle Memorial Homeopathic Institute, Palghar, Maharashtra. Aim for this study was to explore the action of LM potency in bronchial asthma, and objective was to understand the action of LM potency in management of bronchial asthma by using asthma control scale. Why I chose this topic, as we all know, bronchial asthma is a bronchial hyper-responsiveness condition, and very less, it is not much explored with action of LM potency. And bronchial asthma is bronchial hyperresponsiveness, which get provoked with a response of any provoking factor, and it leads to 20% decrease in forced expiratory volume, or as 20% increase in forced expiratory volume in response to any inhaled bronchodilator. If we see epidemiology for bronchial asthma, current estimates suggest that there are 300 million people worldwide who suffers due to bronchial asthma in a year. A study has been conducted in 2011, which states that about 2.05%, that is 7.2 million people, suffer due to asthma in a year. Nearly 5 to 10% of world population at some stage during life suffers due to asthma. If we see the global prevalence of asthma, it has been stated in Global Asthma Network. Globally, about 14% people suffer due to asthma, and mostly those are children's. And there are 8% people who suffer due to asthma, and there are prevalences in India, Australia, USA, UK, Japan, and Africa that we can see on slides. If you see the etiology of bronchial asthma, it is a multifactorial disease. It gets aggravated with many factors. Hello. Okay. It is a multifactorial disease. It gets aggravated with many factors. First, we can see the allergens. There are multiple allergens such as pollen, house dust, cockroaches, mite, pets, which cause the bronchial asthma. There are drug-specific NSAIDs, aspirin, beta blockers can induce asthma. There are exercise-induced asthma as well. There are some infections, especially like rhinovirus, influenza, can cause bronchial asthma. Environmental pollution such as strong scents, perfumes, environmental dust can lead to bronchial asthma. There are some susceptibility genes such as T helper cells 1 and 2, immunoglobulin levels, that is E, and there are some one gene called ADAM33 that can specially lead to bronchial asthma if it level gets aggravated. There are some emotional and psychological factors, if we see in detail, that cause asthma, especially when there is imbalance between giving and taking. These peoples are they try to take too much, that they inflate their lungs, but they are not very much comfortable in giving in form of love or care. And when they try to shut themselves off, whenever there is any life situation which is a normal situation for everyone, but they feel that it is very hard, they are not going to face that, and they shut themselves off. There is lust of power and feeling of smallness. These people feels that they have that domineering streaks, and they are kind of dominating, and they feel they are uh, inferior to someone, and that feeling they refuse to accept in front of everyone, and that they lead into the inflation of lung. There is resistance to dark areas of life. They like to be in uh, neat places, light places, and avoid dark and earthy places. If you see the clinical presentation of bronchial asthma, it is intermittent, irreversible attacks of coughing, wheezing, chest tightness, or dyspnea. Cough is usually followed by wheezing. Nocturnal dyspnea and expiration for wheezing followed by expiration is the common symptom of bronchial asthma. If you see the miasmatic background of bronchial asthma, it is a common belief that asthma is psychotic in nature. but it falls for all under 4 miasm if you see it closely. There are psoric asthma, psychotic asthma, syphilic asthma, and tubercular asthma. Why I choose LM potency in bronchial asthma is the topic, because this LM potency is not much explored in the cases of hypersensitivity. It has been explored in cases where deep pathological cases we have seen, like tuberculosis, cancer, end-stage renal diseases. It has been explored very much there. But in hypersensitive conditions, especially in RS, it is not much explored. It is explored in cases of skin. It is already said that it is the new dynamization, and it lead the chances of aggravation minimization. Material and methods used in this study was, my study design was prospective uncontrolled experimental study where 30 cases of bronchial asthma has been selected. I have chosen 30 cases by calculating it with the formula of T statistics and non-centrality parameter, when type 1 error was assumed at 1.96 and type 2 error was assumed at 80% of power. Effect size has been calculated based on the clinical experience here in Palghar with standard deviation of 1. Calculated sample size was 28 plus 10% dropout, that is 31 sample size. So at the time of this research, 31 samples were enrolled and there was one dropout during the study. Sampling technique was a selective or purposive method. Method of selection was it is based on 3 criteria. Inclusion criteria was all ages and both sexes has been included in this study. Exclusion criteria for this study was the patient, those who are steroid dependent or those who have compromised immunity. Subject withdrawal criteria was status asthmaticus patients. Method of measurement has been used in this study is asthma control scale. It has been applied before, during, and after the treatment. Study instrument used is a standardized case record, and data collection which was relevant to my objective was planning and programming, which has been done prior to the release of medicine. And after the treatment, a remedy response evaluation form has been filled every month to assess the improvement. Data analysis and management procedures in which statistical analytical study has been done and Friedman test has been applied. Data analysis plan and method was qualitative as well as quantitative, where comparison of asthma control scale has been done. So my observation and result which I have been found in the study, in bronchial asthma cases, out of 30 cases, there were functional and structural changes in bronchial asthma. As we can see, in 43% of cases, there were only functional changes, but in 57% cases, structural reversible changes has been found, and it is directly correlated to our repetition of LM potency. So in 33% cases, infrequent repetition has been used, that is weekly once or in 15 days once. In fact, in some cases, monthly once. One dose has been given, but in 60% case, 67% cases, frequent repetition has been needed, where like from 3 doses weekly to 7 doses, that is daily dose has been given. Miasm which I have derived after this study, it has been divided into fundamental miasm and dominant miasm. So in fundamental miasm, 50% cases represented as psychosis miasm, and after that only 29% cases belongs to syphilis miasm, and there were 12% cases belonging to tubercular miasm, and psoric asthma were 9%. And as a dominant miasm, we have found that there was 60% cases that belongs to psora plus psychosis miasm, and purely psoric asthmatic patients were only 27%, and there were 13% cases those who belongs to psora miasm as a dominant miasm, and there were no tubercular or syphilis miasm has been found as a dominant miasm in this study. If you see the susceptibility and sensitivity, out of 30 patients, 22% patients represented with high susceptibility and 8 patients represented with moderate susceptibility. And in while assessing sensitivity, out of 30, 17 patient presented with high sensitivity and 13 patient presented with moderate susceptibility. There were no patient found of low susceptibility or low sensitivity. As I have assessed result after 6 months of treatment, so in 37% of cases, we were able to minimize or control the acute exacerbation. So there were only 37% cases where acute exacerbation has been found, while rest in 63% cases, there were no acute exacerbation in 6 months. In use of inhaler, we were able to minimize in 83% of cases, there were use of inhaler has been minimized. In 11% cases, there were no change in use of inhaler, and in 6% cases, it has been increased. As analysis has been done on asthma control scale, so I will give a brief about what is asthma control scale. It is a scale originated by GINA organization, that is Global Initiation for Asthma. It was published in 2015. It contains 4 criteria, that is daytime symptoms, nocturnal awakening, frequency of inhaler, and activity limitation. Based on this, it is assessed. So if any patient follows all the criteria, it falls for uncontrolled therapy. And if it gets 1 or 2 criteria fulfilled, then it is represented as the patient is partially controlled. And if patient does not fulfill any criteria of all these 4, then he goes for well controlled. So based on this scale, assessment has been done. So out of 30 patients while enrolling, 22 patients were enrolled as uncontrolled asthmatic patients, and 8 patients were enrolled as partially controlled asthmatic patients. So in uncontrolled asthmatic patients, out of 22, we were able to relieve, LM potency were able to relieve 32% patients from uncontrolled asthmatic patients to well controlled. And in 68% cases, we were able to give from uncontrolled treatment to partly controlled. And in those patients who were enrolled as partly controlled, here the result was 50-50. 50% patient gets into partial control, and 50% patient gets for well controlled treatment. If you see the statistical analysis test, as initially pre-experimental test of normality has been done to see the distribution of patient. Here Sapiro-Wig test has been applied, and the p value, as we can see, is 0.00, which signifies that the distribution of sample was uneven. So based on that, parametric test has been selected, and as this study has a multiple repeated measures, so based on that, Friedman test was selected. And here these are the descriptive statistics of every month, as it has been taken for 7 readings before treatment and every month. And test statistics has been applied, where we can see the significance, that is p value is 0.0. It represents that if the p value is less than 0.0, which signifies that it is highly significant. So based on this test, we can conclude that LM potency was highly significant in controlling the bronchial asthma. So what I have concluded in this research, that the prominent constitutional remedy which came out was Kali group, and the anions were used as Kali carb, Kali bichromum, Kali phos were used mostly in these cases. And what miasm we have come, the fundamental miasm was psychosis, where role of antipsychotic medicine, Thuja, has been noted very well, and dominant miasm which were observed was Sora plus psychosis. What we can conclude about the repetitions, where there were functional changes and patient presented with high susceptibility, high sensitivity, in those cases, infrequent repetition has acted well. Where there were structural changes has taken place and patient presented with moderate susceptibility, moderate sensitivity, in those cases, frequent repetition has acted well. So based on that, we can say that there were significant improvement and physical and general level in controlling the acute exacerbation and in minimizing the frequency of inhalers. What I would like to recommend, that someone can do a comparative study of centesimal scale and LM scale to prove the difference between its efficacy. And this study could have been done with a control group, as my study was uncontrolled. So there is no control group has been used. This was my study. I would like to thank LMHI for giving me this opportunity to present my work. And I will conclude here. Thank you.
Thank you, Dr. Hina. This was a wonderful presentation and indeed a very relevant topic in today's time, because we are seeing an increase in the prevalence of asthma cases, especially in the younger age group. Now, I would like to request our esteemed chair, to give their feedbacks or to ask any questions if they would like to ask. Dr. Philippa and Dr. Virendra Sharma, I welcome you, sir and ma'am.
Thank you very much indeed for a wonderful presentation. I really enjoyed it. I was just wondering why you didn't select any patients with compromised immunity. What was your reason for this?
Actually, ma'am, I didn't selected compromised immunity as with the normal immunity and in compromised immunity, the result may change. So I would not be able to conclude at that level whether how much my medicine has acted because the immunity is means already lower in those patients.
You wouldn't have wondered that LMs might actually have worked better for these patients because of the compromised immunity.
Yeah.
Yeah, well, it's good to know. Yeah, thank you very much. That was my main question. I don't know if the other chair has another question.
Thank you, ma'am.
Dr. Hina, you have used the intercurrent in 50 millismol also?
Yes, sir.
Suja?
Yes, sir.
Okay.
Suja has been used in centesimal scale, 50 millisimal
In centesimal
scale
or 50 millismol?
50 millisimal scale only.
Okay. Thank you.
And one other question, just to clarify for the other attendees, how did you apply the LMs? How frequently were they given and in what dosage?
That already I shared, ma'am. It has been given in frequent as well as infrequent doses based on the susceptibility of the patient. So where there were functional changes, it has been given weekly once or in 15 days once. And in some cases, only one dose in month has acted well. But where there were patient presented with structural changes, means in PFT, if you can see there were structural changes, and patient is with moderate susceptibility and moderate sensitivity. In those cases, frequent repetitions like from 3 doses weekly to 7 doses, that is daily dose has been given.
But when you're applying LMs, you're applying it as a liquid potency and you're also succussing. But the dosage, how frequently was this, how much succussion? Was there any systematic for applying this, or was this done individually?
Sorry, ma'am, I didn't get your question.
Maybe this is an international issue. When we give LMs, we're giving it as a liquid potency.
Yes.
And we're instructing the patient how many drops to take and how many succussions, as in how many times to bang.
Yeah, actually, ma'am, here we give it in powder form. We have globules of LM potency, the poppy-sized globules that we crush in the vehicle, that is our saclac. We mix with that and give that powder to take.
Right. So this is we always give LMs as liquid potency. It's an interesting difference. Yeah.
Thank you, Dr. Philippa. Thank you, Dr. Hina.
Thank you.
Now, I would like to call upon our next speaker for the session, Dr. Mridul Kumar Sahani, who is the chairperson of the Research Institute of Sahani Drugs from Patna, India. And he will be presenting an observational study on homeopathic management of bronchial asthma in neonates. Dr. Mridul, the stage is all yours.
Yeah, I'm here. I'm just a moment. Yeah. So here we are in the afternoon. Good afternoon, and my respect to the chairpersons of this session and the moderator. And this is a very good opportunity for me to be here with you all. And my purpose for this presentation is to have a study on the homeopathic managements in bronchial asthma of the neonates. Friends, it is I have to tell you that why I wanted to have this session on the bronchial asthma in the neonates, because I belong to the place, it is Bihar in India, very polluted with the dirts and so many phenomena. And with this, what we feel that we are not.
Dr. Mridul, sir, your screen is not visible. We can just see screen sharing is going on, but nothing is visible.
The blank slide is coming.
Okay. It is coming.
Yes, sir, it is
it's
coming
visible.
now.
Yes.
Okay, okay. It is still coming now?
Now again, we have lost
No,
it.
ma'am.
It was there
Sir,
earlier, sir.
Sir, your screen is in the extended mode, so please
I got it.
make it in duplicate mode and then
I got it. I got it. So, a study of the homeopathic management bronchial asthma of the neonates. The purpose for this neonates presentation is that as I told you, I belongs to the Bihar state, and here there are so many pollutions and the way rural area, it is almost neglected and rural area it is. So in this climatic, we observe so many patients coming to our clinics and our OPDs, and where the neonates are suffering from the bronchial asthma. The purpose was only that it should be make a observational study for this session. So as we are, it is most common chronic childhood disease in nearly all in our place in Bihar. It is more prevalent in children with a family history of atrophy and symptoms and accurations, and frequently provoked by a wide range of triggers including viral infections, indoor and outdoor alignment exercises, tobacco smoking, which is very common, and poor air quality.
sir, your slide is not moving.
I'm just speaking on this slide only, sir. Yeah. So I'll move again. Then this what we observe in the symptoms. It is fast breathing and working hard to breathe, panting with the normal activities, wheezing, persistent coughing, difficulty sucking in or eating, tiredness and cyanosis. And it is because they have much smaller airways than the older children and adults. In fact, these airways are so small that even a small blockage and caused by viral infections, tight airways or mucus can make breathing. So, the aggravating factors that we observed, it was frequent respiratory infections, low birth weight, and poor diet, that lack of antioxidants and exposure of passive tobacco smoking before and or after the birth, and being raised in low income environment. This is very common in our place. It is the measure we adopted. It was a single blind placebo randomized control study, and has been adopted to know the efficacy of homeopathic medicines in management of asthma in children. And we took total number of 30 patients were selected for fulfilling the inclusion and exclusion criteria. Follow-up has been taken for 3 months with at least 3 visits, and from every subject a written informed consents were taken. And then the aim and objective was to study the case of neonates suffering from bronchial asthma and find out its management using homeopathic medicine selected on the basis of totality of the symptoms. And to study the therapeutics related to pediatrics cases of acute bronchial asthma of the neonates. The hypothesis, we had the alternative hypothesis, improvement in cases of asthma neonates following treatment with homeopathic medicines. This was on the basis of totality of symptoms, is because of sampling variation. The result is not statistically significant. The null hypothesis, improvement in case of asthma in neonates following treatment with homeopathic medicine on the basis of totality of symptoms, is the medicinal effect. The result is statistically significant. Inclusion criteria, the cases were diagnosed in as in the 2015 version of ICD-10 CM diagnosis code J45.90, and neonates were born with cesarean section in full pregnancy terms. This was our inclusion criteria. Yeah, and the age group where the two patients were between the 2 weeks, then there were 3 weeks patients were there, and 4 weeks. And the age group where yeah. The sex ratio was 40% was the 40% was female and 60% was male. And religion, we have the varied religion. Most of the patients were from Hindu religion and few were from the Muslims. And socio-economic status was 0%, 17%, 20% and 63%. So most of the patients were belonging to the lower group and the low middle income group. And habitats, we see that most of the patients are belonging to the rural area. Results results three only we can see that only 3 patients were cured, and then there was a marked improvement in the 16 cases, and improved cases were 15 and not improvement was 2, and the 2 patients dropped out. So total number of 30 patients, only we observed that they were fully cured. This is the experimental groups. We had the cured cases. This is not cured cases, 25, and this is the ratio. Control cases was there, so total 30 patients were there. We calculated the value as with the T-square value. So this is the result, differential is the result. And since calculated value is x power 2 and total value was x power 2, so p value was more than 0.5. So alternative hypothesis: improvement in cases of asthma in neonates following treatment with homeopathic medicine on the basis of totality of symptoms is a medicinal effect. The result is statistically significant. So all data were calculated from the study of 30 individuals. Statistical regarding the various parameters were conducted, and ratio of cure was found out in relation to the medicines used. The conclusion that we arrived was in this present study, the homeopathic treatment for management of asthma of children is found to be more useful, and the only thing that constitutional treatment is very much effective and it has to be taken into considerations. So these were our observations. The medicines that were used were from the general pool of the homeopathy. So this was our short study of the 3 months durations only, which we conducted only after this during this the beginning of the end of the last 2020 and continued till the beginning of the this present year. And what we observed that these patients from the rural area as well as from the semi-rural urban area are very much useful, and they find it more. It can be a very good information for them. So I thank you very much for getting a time from for these presentations, and I feel that it will be a good presentation.
Thank you very much, Dr. Mridul Sahani, for your wonderful presentation. I can see Dr. Virendra Sharma has joined us, and I would like to welcome you, sir, in this session.
Hello.
Yeah, if you have any questions, madam, then it will be.
Yes, I would like to welcome Dr. Virendra Sharma, and sir, if you have any questions, please go ahead.
Actually, sorry to say that I could not hold the lecture due to some network problem. So anyhow, in the last moments, I came to know that it was a case of acute exacerbations of the bronchial asthma, especially in neonates. So it is a good observational study, and moreover, the result of study shall benefit the homeopathic vernatility. Thank you very much.
Thank you, sir. Thank you very much.
To give her comments and to ask any questions if she would like to ask any.
Thank you so much. It's obviously a very necessary study in the state of Bihar, which I'm sad to hear is so needed. My questions are from an academic standpoint about.
I would like to request everyone to keep their speakers on mute, please.
Yeah, that's better. Yeah.
Thank you.
So you described it as a single-blind, placebo-controlled, randomized controlled study, but we didn't have very much information about the two groups and how you did the randomization and the numbers in each group. I wonder if you could expand a little bit on this part of the study.
Thank you, madam, for your nice question. Definitely in neonates we find difficulty in getting but objective symptoms are very much prominent, and what I feel that if you more concentrate on observing the children as well as, because there are so many body languages being observed that we have found in this in all these patients. Some mental presentations of the body language as well as the pain and the way they react. This is while we were selecting the medicines from repertory, I mostly try to have the medicines from the repertorial selections, and where I give preference to the mental symptoms. So in the neonates also, the mental symptoms are visible and as observed by the mothers, as well as what we see during the clinic hours. So we are able to find out so many things and get it associated with the presentations, how the child is working. So this is for me to share with you that you have to learn, you have to become an observer, good observer, to get the symptoms of the children. Thank you, ma'am.
I apologize. I don't think I explained my question quite right. It was actually about your trial design. You described it as a placebo-controlled randomized trial, single blind. And I was wondering about the two groups, how you decided, or how you randomized, and the numbers in each group.
Ma'am, definitely it is a difficult things to decide from the neonates, but it was randomly selected and we didn't have any criteria for that time, and we only randomly put in the two groups.
And were they equal? They were equal, the two groups, 15,
Yeah,
15?
they were equal in the two groups.
Okay, thank you. This is what I want.
Thank you, ma'am.
Yeah. And who was blind in this study?
Pardon me, ma'am?
You described it as a single-blinded study.
Yeah, no, yeah, just like Mr. telling you like this, but it is what we divided into the two groups.
Right, okay, thank you.
Thank you, Dr. Sahani, and thank you, Dr. Philippa, for your valuable feedback and questions. Now, I would like to request our next speaker, Dr. Seema Mahesh, who is a research scholar from Taylor's University, Malaysia, and will be presenting a case control study on correlation between acute and chronic inflammatory states. I welcome you, Dr. Seema.
Namaste. That's easier than good morning, good afternoon, good evening when there are so many time zones. Let me start by sharing my screen. Is it visible? Am I audible?
The screen is visible and you're audible as well. Please go ahead.
Thank you. Thank you. So what I'm presenting to you today is a very broad based idea. I know that you're going to have a lot of questions at the end, but bear in mind that this was just to get the idea out there and to get a feeler about what we may find if we go into the specifics. So it's a study to find out if there is a correlation between acute and chronic inflammatory states, and we did it by a case control study. I want to explain the background a little bit because I think it's very essential. All the immunological studies say that when you have an infectious agent, a pathogen infecting you, if you are a healthy immune system, you raise a fever and you combat the infection and you go back to your normal state. Now, what happens if you don't allow that fever to run is what happens with suppression of inflammation, acute inflammation. And this has opened up a whole new research area today, which is called resolution of inflammation, where they're studying that chronic inflammation is actually a failure of the acute inflammation to resolve. So, which means when we continuously suppress acute inflammation, there is a sort of a constant, going nowhere sort of subacute inflammation, which eventually activates or triggers the chronic inflammatory state. Now, the immunological studies stop here, but the continuum theory by Professor Vutulkas goes ahead and says, so if you treat this chronic inflammatory state is a chronic disease, with homeopathy, then, and the disease improves, then you will see the return of the ability to raise a high fever with acute infections in that person. Now, it's all, and of course, it's a Hahnemannian idea which is adapted to today's immunological background. So to tell that in theory is fine, but do we actually have any clinical evidence to see whether there is actually this phenomena happening in the clinic? So to see out there in the real world scenario, if there is a correlation between chronic inflammation and efficient acute inflammation, the emphasis on efficient acute inflammation. The method we used, we designed a case control study, a very small case control study. We selected patients who were diagnosed with chronic inflammatory conditions. That's why I said it's a very broad study. We did a lot of other specific ones later, but this was the initial one, which was very broad. So our criteria was that the patient should have been diagnosed with a chronic inflammatory condition, been under homeopathic treatment for at least 6 months. And we collected data from nearly 20 of our colleagues from all over the world. We asked for the data, and we divided the cases and controls as such. Cases involved 20 patients who improved under homeopathic treatment, and controls were those who did not improve under homeopathic treatment in this follow-up period, at least 6 months. Now, the event of interest for us in this follow-up period was the occurrence of common acute infections with fever. This was what we were looking for. And we sought to analyze the odds ratio of improving with respect to development of acute infectious diseases. And we also plotted the graph, throughout the past history, the present history, complaints, and then the follow-up. We plotted the graph of the symptoms. So this was the design and the methodology. And the results, we were expecting some correlation, but we were really floored when we saw that 18 out of 20 of our cases had developed acute infections with fever during the follow-up, whereas only 4 of the controls had developed fever and acute infections. So obviously the odds ratio was very high, 36 with a wide confidence interval. We have a small sample size, very wide confidence interval, and it was statistically significant. Now, going on to show you the graphs, these are the cases. That means these were cases that improved under homeopathic treatment. Now, look at the correlation here with the follow-ups, on those dates. There is a very clear correlation between the decrease in the cervical pain and onset of acutes. And these acutes became more common as we went through the follow-ups. The same with the autism. The CAR score started improving and the acutes became more and more common. And with 40 degrees fever, you can see that. And even here, which is a very serious condition, the hippocampal sclerosis with epilepsy, the mental dullness all started to decrease around the same time that fever started to show up. And this case, the last one, we have 20 of these cases I've taken on before as examples. The last one is not an acute, but another phenomena that came through, which is the return of suppressed dermatitis as the epileptic seizures went away. Now, the epileptic seizures were also of acute onset, so it was not something you expect to last for a long time. It went away on the 15th day and did not occur after that, but the dermatitis in the child that was in the girl that was suppressed before came back, and it peaked 2 months after the epilepsy went away. So there was a very obvious correlation apparent to us on the in the symptoms, that as the chronic inflammatory symptoms improved, there was an ability in the organism to raise a high fever, to react to the pathogens with an acute inflammatory response. If we saw the controls, on the other hand, if you look at this patient did not improve considerably, and there is no acute at all here. And in this case, let me finish this one. Here as well, the seizures, they were a little better. It's not very, it's not a cured case, and we did not see any acutes here. And you see, even in controls, if there was a fever, it was associated with reduction in at least one of the symptoms, even though it's not a cured case, because we're looking at arrested development here, which did not improve. The epilepsy did improve, probably because arrested development goes beyond inflammation. Let's not get into that part. But here, the epilepsy, which is definitely inflammatory, became better with the, correlated with the onset of fever. Now, the same thing happened here, where the eczema did not improve very well, but around the time the patient put up a fever, there was improvement in the chronic inflammatory condition. So even in uncured or cases that were not cured, around the time that they put up acute inflammatory response, we saw a definite improvement in the chronic inflammatory condition. So obviously, there is a correlation between the prevalence or the existence of the chronic inflammatory state in the body and the inability of the organism to put up reaction to common infectious pathogens with efficient acute inflammation, which is characterized by high fever. So the conclusions of this study were as follows. In this case, control study, appearance of common acute infectious diseases with high fever was strongly associated with improvement in the chronic inflammatory conditions. Of course, it's a small study, very wide study. We need larger, finer studies to establish the correlation. And if established, this is the point that I want to emphasize upon, this correlation may change the way we handle the acute infectious diseases in practice. Even not just homeopathic practitioners, but also the conventional medicine. If we make them aware as to how important it is to preserve the immune response, then maybe this whole practice of over-the-counter medications to over-medications may come down. Thank you. Any questions?
Thank you so much, Dr. Seema, for this interesting study and a wonderful presentation indeed, a very educating presentation. I would like to request our esteemed chairs to ask the questions and to give their valuable feedbacks.
Shall I start, or does my co-chair want to speak?
You can start, ma'am. I think Dr.
Okay, I'd like to congratulate you on a very exciting series of work. And first of all, for designing a study that can actually capture these kind of results, because I understand it's a very complicated finding to find. As you can hear, I'm very excited by what you've done.
Thank you.
And I really look forward to seeing some more progress, because I think you've identified such a very, very important issue and managed to describe it and capture it. And then I'm wondering if you have decided if there are any specific inflammatory states that you're going to focus on in going forward.
Thank you, Dr. Fibert. The thing is, after this particular study, this actually we designed for a very specific conference, and we wanted to take some data on this, and we worked a lot for nearly 6 months. But once we presented there and certain questions came about, just like you asked me, and they said, you're talking of a very broad-based study, can you tell us on specific conditions? We did at least, I think, 4 different conditions. We did diabetes, we did chronic headaches, and I think we did multiple sclerosis, which we presented at Harvard actually. So when we studied the correlation between the onset, like when they were diagnosed with diabetes until now, if they have had any fever at all, we were looking at it, because most of the diabetes cases were not really cured at the time we were looking at. They were better, but not what we would call cured. Very few cases that we would call as cured, very few cases, because you follow them up and the HbA1c stays consistently low for a long time, you would call them cured. But as homeopaths, we have different criteria to call them as cured. We need to see shift of pathology to a better situation, right? So the ones who were really cured definitely showed acute inflammatory reactions. Like, for example, they caught the epidemics very easily, not COVID, let's not go into COVID, but I'm just talking about things like dengue, chikungunya, and things like that. They caught them more easily than the ones who were, on insulin, not responding, these conditions. Same thing with the chronic headache cases. Since the diagnosis till now, at the point when we were looking at, if we looked at the history, they definitely showed a reduction, especially if we're looking at school children, before the onset of headaches, and later they showed a very obvious reduction in the acutes that they were developing. So, and as they improved, this was in Italy, the study was done in Italy, and as they improved, they definitely showed a return of the fevers and infections. So even in specific conditions, we were able to appreciate this actually.
Yeah, I would be very interested to see it in autism, which is my area of speciality, because I've definitely observed it in clinical practice. In fact, it's what we tell our patients, don't we? Has anything been done in this area yet?
No, as a part of this study, we had 2 cases of autism that showed very beautifully this correlation. And one of them for a very long period, follow-up for like 20 years. Okay, so it's a very, I can send you the poster of that particular patient if you are interested. You can see very beautifully the shift of the inflammatory response from being predominantly, the disease symptoms being autistic to being acute infections. And it is very, and the boy actually went on to join university and he's really doing well. So such cases, you actually see the principles like, like stories on screen. So yeah, we did see that.
But I'm wondering about the PANS and the PANDAS conditions that are now emerging as an issue and their relationship with this hypothesis.
I don't have any case on that. But I would say I would think that as long as there is a real cure, like how we define, as homeopaths define cure, I think we will still see this phenomenon. Because I did not expect to see so much of data, so easily coming out. But I was really surprised. I thought, okay, a little bit will be there because we have this principle, but it's very obvious.
Yeah, this is the best kind of study, isn't it? This is surprising results. Yeah. No, again, I don't want to hog the stage anymore, but I would really like to congratulate you and wish you the best of luck going forwards in this very important work.
Thank you. Any more questions?
Thank you, Dr. Philippa. Do we have Dr. Birinder Sharma with us? Sir, would you like to ask any questions?
Yes, Dr. Seema.
Yes, sir.
I have one question that regarding your study, especially in the inflammatory conditions. And in one case, you have referred that in case of hyposclerosis with epilepsy, the dermatitis returns. So can you correlate the whole study with the homeopathic literature, or especially with the organ, like as the hearing loss cure, or from more important organ to less important organs, or from inner to outward? I think if we will correlate with such a type of cases with our literature, then I think our milestone should be decreased. And similarly, in your study, you have not considered any inflammatory marker for the regression or progression of the disease. So this is again my advice that you please consider the inflammatory marker along with your scientific evaluation, so that we can put such type of cases on the forum or on the some you can say international stage for consideration. So thank you very much.
Thank you, sir. Actually, I would like to clarify that I have presented only the clinical part of it, but each of these cases have been handled by different physicians from different centers, and they have the data that shows the actual regression of the inflammation in each of these. For example, psoriasis cases, we have very clear markers showing that the inflammation in the body has reduced. The CRP, which was very high during the acute exacerbation, goes down to normal, stays that way for over 3 years, does not come back. Even for example, if we're looking at certain chronic conditions like diabetes and things like that, if we look at the HbA1c, that has been recorded. So even the inflammatory markers by the physicians has been recorded. But here, for the graphical appreciation, I have put forward only the clinical symptomatology because it's very appreciable, that's also. So thank you for that advice.
So nice.
Thank you so much. Thank you so much, Dr. Birinder Sharma, for your question. And thank you, Dr. Seema, for this wonderful presentation. Now, I would like to invite our next speaker, Dr. Surbhi Jain, who is a research associate from Central Council of Research and Homeopathy in India. And she'll be presenting her observational study on the utility of Fatak's repertory in acute cases. I welcome you, Dr. Surbhi.
Yeah, hi. Thank you so much for giving me this chance to present before LMHI. Is my screen visible?
Not yet. You'll have to start your screen sharing. Yes, now it has started. We can can see the presentation. You can just start with the slideshow. Now it's there. Thank you.
Okay, so my sincere greetings to one and all. Today I'm here to present my research experience on the topic utility of Phatak's repertory in acute cases and open observational clinical trial. First of all, I would like to share with you that who was Dr. Phatak. Dr. Phatak was actually an allopathic physician who was converted to homeopathy due to the serendipitous discovery, due to the serendipitous recovery of a patient. Actually, he was treating a patient already with allopathic medicines for a long time with no relief. That patient had icy coldness between the shoulder blades, and he couldn't treat it with any allopathic medications. No other medicine was working in that patient, and so he by chance came across a homeopathic book in which he read about ammonium miraticum, and the symptom that was written on that book was the same symptom that the patient was presenting. And so he went to the pharmacy to take this medicine, ammonium miraticum, but he had no idea that how is homeopathic medicine given, in which potency. So he took 30th potency and he gave it to the patient, and the patient, to his surprise, was cured of his symptom within just 2 to 3 days. And so this is how Dr. Phatak was, Dr. Phatak, who was an allopathic physician, converted to homeopathy. So Dr. Rajan Sankaran has very rightly said, it was as if the masters of past were alive in Phatak, speaking through his work. At that time, I had no idea that Phatak's book would, in the next 2 decades, become one of the most widely used books in the profession throughout the world. The reason why I chose this topic was that I've seen that that is a general misconception amongst the masses that homeopathy is slow and we can't opt for homeopathic treatment in acute cases. So I wanted to give a justification, or I wanted to explore acute cases with the help of Phatak's repertory, because Phatak's repertory is a concise alphabetical repertory. So I felt that in acute cases, this could prove useful. The aim of the study was to evaluate the utility of Phatak's repertory in acute cases. The method used was the methodology was basically an open label prospective observational non-controlled clinical trial that was conducted at Dr. MPK Homeopathic Medical College and Hospital and at Homeopathy University, Jaipur. This was conducted for 1 year. This research was undertaken for 1 year during 2012 and 13 with the approval of Institutional Ethics Committee. The sample size was 50, and the selection of cases was done by convenient sampling, whichever patient was coming to the OPD presenting with acute complaints was enrolled in the study. All the acute cases were taken irrespective of the age, gender, caste, religion, anything like that, and detailed case taking of each case was undertaken on a prescribed case performer. The intervention was planned as the administration of single indicated homeopathic medicine in centesimal potencies and individualized dosage based on acute totality with reference to Phatak's repertory in conjunction with homeopathic principles. The follow-up of the patients was done as per the gravity of the case. Per protocol analysis of the outcomes was done using 4-point grading scale, that is marked improvement, mild improvement, status quo, and worse. So this is the outcome criteria, the 4 parameters that were devised according to the type of response which was obtained after treatment. Marked improvement when there was a feeling of mental and physical well-being with disappearance of all signs and symptoms for which the patient initially approached without any recurrence of symptoms till the completion of study. Mild improvement was considered when the patient had a partial relief in some of the signs and symptoms in terms of frequency, severity, but not a complete disappearance of the symptoms in spite of taking the medicine regularly. Status quo when there was no change in the condition of the patient in spite of taking the medicines for a long time. And worse, when there was no improvement in the condition of the patient and instead his health was deteriorating. So these were the four criteria that I took. And the results were actually there were 54 subjects who were enrolled, but only 50 patients completed the trial. So per protocol analysis was done, and finally the N was 50. A majority of patients reported marked improvement. That is, out of 50, 41 patients reported with marked improvement. 3 patients reported mild improvement, and status quo and worse categories were 10% and 2%. A total of 28 different medicines were prescribed for 50 cases, which highlights the wide coverage of medicines in this repertory. Pulsatilla, Nux vomica, Rustox, and sepia, which are polycrest remedies, were seen to be most indicated in most of the cases, with each remedy covering 5 cases each. They were prescribed most frequently. And 105 rubrics from Phatak's repertory with respect to 26 remedies in 18 diseases were validated. This is the...
I will request you to please wind up in the next 1 minute as we are running short of time.
Okay, yeah. So this is the demographic data that we have according to the skin diseases were maximum, and ENT and GI symptoms were also, the diseases were also seen, and the maximum incidence, the result and the incidence of medicine. So there's a interesting case of dysmenorrhea. In this case, the patient she was a 18-year-old female who was unmarried, and she presented with dysmenorrhea, spasmodic dysmenorrhea. In this case, the patient was sitting in the namaz position with her ankles pressing upon the vulva. She was feeling a bearing down sensation in the vagina. She was very restless. She was moving back and forth, and she was sitting in a kneel down position with her thighs tightly approximated so as to press the vulva with her ankles. So these are the 3 rubrics that I took, and the remedy that came to be with highest marks was sepia, and which was prescribed, and the patient, these are the rubrics with the corresponding remedies in the 3 rubrics. And the patient was found to be relieved within 10 minutes. After giving this sepia 200, 1 dose stat, the restlessness was decreased, but the bearing down sensation and the pain abdomen was not relieved. So after 10 minutes, the sepia 200 dose was repeated, and after which, after 10 minutes, the follow-up was taken, and the restlessness and the bearing down was also better. And gradually, after a period of another 10 minutes, the patient was completely relieved of her symptoms. So this is the magic of Phatak's repertory. And so the conclusion that I would like to make is that it is indeed a useful tool for efficient and quick acute prescribing, and acute diseases have self-limiting course, and the outcomes need to be further validated with large sample size, and another comparative group trial can be done. So Dr. Phatak, with my poor intellect and limited knowledge of homeopathy, I have tried to fulfill Dr. Boger's wish. How far I am successful in my attempt, only time will show. I have done whatever I could. Capable young homeopaths should carry on the work further. Thank you.
Thank you so much, Dr. Surbi, for this tribute to Dr. Phatak's repertory and this wonderful presentation. We are running a little short of time, so we can keep the Q&A for your session in the end, if that's okay with the chairs. And we can move ahead with our next speaker. So now I would like to welcome my co-host, Dr. Shelly Arora, to take on the virtual dice and invite the next speaker.
Thank you, Dr. Nirmal. Now, since we are running short of time, we can take the questions in the end. And now, coming up, we have our next observational study from Muzaffarpur, India. We have the paper presented by Dr. Amit and Dr. Sabiha, who are from RBTS Government Homeopathic Medical College and Hospital. They are going to present a comparative retrospective cohort study on belladonna as a prophylactic in acute encephalitis syndrome in Muzaffarpur. I would request Dr. Sabiha. Dr. Sabiha, can you start your presentation, please? Yes, you can start the screen sharing.
Ma'am, is my screen visible?
Yes, yes, now it's visible. You can start, please.
Greetings, welcome everyone. Thank you for being here today and deciding to cover your theme for a couple of minutes. This topic, as per this study, was led by Dr. Amit Sahani, Assistant Professor and HOD Department of Laboratory. And unfortunately, because of his absence today, he has empowered me for the event. So without further ado, let's get into the topic straight away. So, as we know, outbreaks of an unexplained acute neurological illness affecting young children and associated with high case fatality rates have been reported in Muzaffarpur district of Bihar since 1995, with generally peaks in June and declining the peaks rate of the onset of monsoon rains. There have been a wide spectrum of proposed causes for the illness, including infectious encephalitis, leaching fluid toxicity, and exposure to pesticide toxicity as well. So, as a result of which, in our institute, there is this prophylactic given to the children in pedia OPD, which comprises of belladonna 200. Going ahead with my study, seeing the background, as we know, acute encephalitis syndrome has been a long-term public health concern, and we have assessed the effectiveness of belladonna in the protection from AES during the peak period of the year 2020, because as we are all aware, belladonna, a homeopathic plant extract, has been traditionally used for clinical presentations similar to that of AES. In this retrospective study, we have analyzed the medical records and of all the patients visiting the outpatient department of the pediatric ward of our hospital from April to May, and this comprises of the cohort comprised of all the children who visited pedia OPD from 1st April to 31st May, and belladonna was administered. The outcome in such cases was incidence of AES symptoms, which was then compared between the exposed and non-exposed for a period of 6 months from the enrollment. This was a telephonic interview and medical records were reviewed, and the participation was voluntary, and informed oral consent was also obtained from the patient's parents before the data collection. The aim of this study was to assess the effectiveness of preventive treatment with belladonna for reduction in the incidence rate of AES during the peak period, as well as to determine the duration and intensity of symptoms of AES, and also to assess the relative risk. So we started with the hypothesis that there will be no significant difference between belladonna and the control group in reducing the AES incidence of AES symptoms, whereas alternative hypothesis states that there will be a significant difference between belladonna and the control group medicines which are given to the patients. With this hypothesis in mind, we moved ahead with the enrollment, where we identified 100 patients in prophylactic group, that is belladonna group, and 100 patients on the control group, which comprised of all the patients taking medicines for their particular conditions during that. Among the 100 patients in homeopathic prophylactic group as well as the control group, 10 from each of the groups were not eligible because
I think she has some network problem. So
Yes,
you may please call the next speaker so that we may continue later on.
Okay, sir. Okay, so since we have some network issues, actually it's a problem. She may be in some part of India where such a problem arises. Okay, so we move on to our next speaker, that is Professor Dr. Dilip Nanda. He is from the Department of Medicine. He is HOD there in Srimati Malini Kishore Sangvi Homeopathic Medical College and Hospital. And he would be presenting a case series, a cross-sectional case series on establishing the role of mental state in the genesis of essential hypertension and its importance in the selection of its simillimum. Dr. Nanda, you may please start your presentation.
Yes, madam.
Welcome, sir.
Good morning, good afternoon, and good evening to many of us.
Yes, sir, you are
Yes,
audible.
sir, your audible and screen is also visible.
Okay,
Yes,
thank
sir.
you.
Everything is fine.
Thank you very much. So what I am going to present today, trying to establish the relationship between mental state for the genesis of essential hypertension and how it is significant in the selection of simillimum. It is a cross-sectional case series. So what is the plan of the session? We are going to take why of the study, how the study was conducted, and what do we mean by mental state, mental symptom, and disposition? What is the relationship between stress and blood pressure? We will try to see what are the background has been created by taking various review of literature. What instrument we have used for the analytical tool we have used, and the result and the conclusion, and what are the references we have taken. So, as we know, in today's present era, diseases related to lifespan are increasing, lifestyle are increasing. Hypertension is one of the widely prevalent health issues over the globe. Studies indicate that hypertensive patient has a history of continuous or circumstantial mental stress as a causative factor for their illness in the addition to the physical, genetic, and non-specific factors responsible directly or indirectly for the development of high blood pressure. Now, what we have seen, studied during our college, that in aphorism 225, Dr. Neyman has rightly identified. So there are various diseases which arise due to the emotional issues as a psychosomatic nature. Now, in patient of hypertension, there is a need to establish a temporal correlations with the life stresses, its role as a causative modalities, and as a factor for the selection of simillimum. Now, how the study was conducted? So, design and method. So, it was a qualitative study where the purposive sampling method was chosen. 10 cases of hypertension was selected. Lifespan events of these cases were done through the cross-sectional and longitudinal analysis. Then we tried to establish the correlations between stressful events and the effect at the level of mind and body. And then we try to establish a remedial correspondence, similarity, depending upon the mental causation state and the physical symptoms. So before we proceed, we must be acquainted with this terminology. What do you mean by mental state? Mental state is a combination of different categories of mental symptoms, that is symptoms of intellect, emotion, and behavior. Now it is in an influx or a change over a period of time. It is dependent for its particular expression on the environmental circumstances, and it arises from a deeper entity like disposition. So mental state depicts a current state the person passes through with respect to his intellect, emotion, and behavior. Now, what is mental symptoms and dispositions? Because getting acquainted with this terminology is very essential for understanding the patient symptoms and dispositions. Now, it is a phenomena experienced subjectively or observed externally, unclear under certain specific conditions. Whereas mental disposition is best termed as an attitude or a manner of relating to the event, which is relatively stable over a sufficient long period of time, which you can count in years. Now, what is the relationship between a stress and blood pressure? Now we are aware with the PNEI axis, which talks about a stress which is felt in the brain, the information of stress which goes to the amygdala, which is known as the emotional processing center. Now this center interprets the stimulus and send a distress signal to the hypothalamus. Now here hypothalamus, which functions as a command center, is the highest autonomic ganglion, which communicate to the autonomic nervous system. Now this system controls all involuntary body functions. So this is in way the stress goes to the specific organ, CVS, adrenal gland and blood vessels. So in the next slide, we will try to see in what way this relationship get established. Now from the brain, there's a direct stimulus on the adrenal gland, which gland of adrenal medulla and cortex release the catecholamine and corticosteroids simultaneously. And epinephrine, non-epinephrine has an affinity to increase heart rate and contractions. In this turn, it increases the cardiac output. Whereas aldosterone will have a direct impact on renin-angiotensin cycle, which will increase the renal retention of sodium and water, and that's how it will increase the cardiac output. Now, from the brain, there's a direct autonomic nervous system. Sympathetic stimulus goes to the blood vessels, which produce vasoconstrictions. Now, vasoconstriction will have a direct impact on peripheral resistance. So this is in way we are able to get a sympathetic stimulus having an overactivity at the level of tissue and its function. So in the next slide, we are able to understand the pathophysiology of hypertension, in what way the cardiac output and peripheral resistance, which works normally in an auto-regulation manner. So there are various causes which can lead into the increased hypertension, either depend upon increased cardiac output or increased peripheral resistance. So these are all stated causes like excess sodium intake, genetic or stress or genetic alterations, obesity and endothelial derived factors. So these are the different mechanisms in which there is an increase in the cardiac output. Now we are interested in understanding the stress. So we have seen in earlier slides, but the sympathetic nervous overactivation have a direct impact on increasing the peripheral load by venous constrictions and increasing contractility. That's why it goes for the hypertension, increased blood pressure. At other level, it has a functional constriction at the peripheral vessels and produce a functional constriction. And if there is a repeated chronic stress, a person have a structural hypertrophy in the blood vessels. So this is how we are able to see the correlations of stress with the different pathogenesis of the hypertension. So now, once we have acquainted this knowledge, how we are able to see the different articles talking about the increased risk of hypertension. So one of the article was talking about a mental shock or an attack of anger will increase the discharge of adrenal in the blood. One of the article was also talking about association of general anxiety disorder and the major depressive disorder. So one of the article also said that person with a major depression has a 60% higher risk for the hypertension. Woman with a poor mental health has a high risk as compared to the good or accidental mental health. One of the study was talking about mental emotional situations, like what we are also trying to find out the different situations. So they have not gone into the deeper part of how the analysis can be done, but they have said that there are mental emotional situations which have a high risk for hypertension. There are 4 or 5 studies which I came across. The subject with the anger, anxiety, and depressions have a high incidence of hypertension. Now, we as a homeopath, we should try to study the life space events of the individual. So when I took article reviews, I could not see any tool which can able to identify these correlations. So what I have found is a life space table, which is an instrument to derive characteristic expression thrown by the patient from time to time in the life space, and we are able to make these correlations very effectively. So we will see what this table is. Now, this table is an analytical tool for the cross-sectional and longitudinal study of the life space. Now, on a cross-sectional event, this is a 9-column under which we can understand do the analysis. So if there is a patient has any specific event, we need to identify the onset and duration of the event. Life space situations talks about the environmental factors which interact and what the characteristic expression the person's experience during this event has to be identified, and what are the precipitating factors and what are the attributes we are able to derive. Now, when we take a longitudinal study, here we will be able to see the pattern of response and individual experience or expressed from time to time over a period of time, and we are able to derive a continuous attributes which we can define as a disposition quality. So in the last column, we have a chances of going deeper part of understanding the psychodynamic point, how each individual experiences. So in all 10 cases, this is how we have done a qualitative study by identifying the different blocks and the different events and making the dispositional quality and correlations. Now, what result we have identified by doing this detailed analysis? Now, there are the distinctly three groups we could identify: the life space stressors, the event. In one of the group, there was early responsibilities, financial instability, and illness contribute to the mental state and symptoms of constant anxiety about health, family, and financial. So this group has predominantly anxiety and anxiety specific of a quality type of responsibility. Now, this group of patient disposition quality we have identified as anxious and conscientious. Another group has a strained IPR relationship with the mother-in-law and husband. Now we are able to see this strained relationship produce a violent anger, brooding, suppressed anger, and indifferent state. Now, as far as the mental causation is concerned, we were able to see the suppressed anger as a causation, sensitivity to contradiction and criticisms in this many percentage, and the disposition quality we could derive among this group is irritable. The last group which we could able to identify the theme of loved one, either it is death or disappointment in love. Now, this group of patient went into weeping and suicidal thoughts and has a causation of grief. And when we understand through the life space table, we are able to see the sentimentality as a dispositional quality among them. So what I am trying to bring the concept behind is that we need to establish these correlations. So if once we are able to establish, we are in better position to understand materia medica correspondence. Now, similarity was established on the basis of mental causation, mental state, and the physical symptoms. So now if we correlate the last slide with this slide, we are able to see the remedies like Natrum group coming up as a 30%, 40%, where we are able to see the responsibility and the disappointment in love and the death of loved one and grief. Now, whereas the responsibility, conscientious, and the irritability, aurum, indifferent state in terms of sepia and calcarea and lachesis. So this out of the 10 hypertensive patients, we are able to raise these conclusions. So now, if I sum up, that essential hypertension has a strong temporal correlations with the emotional mental state as a precipitating and maintaining factor. An individual who is anxious and irritable, having difficulty in handling the effect of stress, has a higher chance to develop essential hypertension. And if you are able to do it up to this level, then identifying similarium or making a remedial correspondence will be easy, because we will be able to erect a totality based on the mental qualified causation, symptoms, and the disposition quality. So these were the few references I have represented. References are 25, but for this presentation, I have presented here the references which were taken for the study, so that we can define our methodology for the further of these hypertensive cases.
Thank you, Dr. Nanda. I think his internet issue. Yeah, thank you, Dr. Nanda. It was indeed a very relevant topic in today's modern world, where I think there is a significant increase in lifestyle disorders, and it manifests itself in a variety of diseases like hypertension, you've just said, and diabetes and other thyroid disorders as well. So now I would request the chairpersons, Dr. Sharma and Dr. Fibbert, to please ask questions if you have any.
Hello, Dr. Dalip. Your presentation was very nice regarding the mental state aspect of the hypertension. So it has been proved since decades that hypertension is the results of stressors which cause in our daily life, and moreover it is a basic lifestyle disorder. But from homeopathic point of view, that what we proved, that is suppressed anger.
Sorry, there was a Sir, there was a light fluctuation. So last slide I have not shown. If I don't know whether you have gone through the last slide or not. Acknowledgement.
I think you have not shown that slide.
Yeah. So because there's a light fluctuation and light has gone. Now this is the last slide. I would like to acknowledge. References, sir, we are able to take. No? Yeah. So this is the acknowledgement for all master, patient, and student, and teachers, and the software and the institute for allowing and creating this presentation. Yes, sir. You are asking something.
Okay, thank you. So with these, the medicines you have grouped, I think natrum is on the top, and even in clinical practice, we have seen that natrum responds very well to the hypertensive disorders, and similarly, this lachesis, which has a upper hand in the hypertensive disorders. Similarly, I think you have not mentioned the belladonna, which is again a very good medicine for hypertension. Paramet, again a good medicine for. So if we'll refer your all therapeutics with our references to the materia medica, I think the proving come with the materia medica, and it is a good effort to prove and to correlate the incidences of the hypertension with the medicinal symptoms. So thank you very much.
Right, sir. Thank you.
Thank you, sir. Dr. Fibert, if you have any questions for Dr. Nanda?
No, I have no questions for this presentation.
Okay, thank you, ma'am. So let us move on to our next presenter. We have with us Dr. Nishant Daryani. He is a chief physician in the homeopathic migraine clinic in Jaipur, India. Now, he would be presenting an evidence-based case report on Hashimoto's thyroiditis with migraine. Dr. Daryani, please.
Thank you.
Yes.
Am I audible?
Yes, sir. We can see your presentation as well.
Okay. Greetings to the respected chairs of the session and learned homeopaths. I'm thankful to the LMHI for giving me an opportunity to present this paper. Mrs. MD, aged 37 years, housewife, presented with easy exhaustion, aching pains in extremities, hair fall, difficulty in falling asleep, body weight variable without any efforts, heat sensation in soles at night. She was also complaining of hemicranial pains in either side, mild to severe episodes 2 to 3 times in a month that last for 1 to 2 days, usually without any cause except occasionally around menses, associated with nausea, and generally gets worse in morning after rising from sleep, and feels temporarily better from pressure and rest. History of presenting complaints. Patient was apparently well 3 years back. She was cheerful, active, doing her household activities very well. Gradually, her energy level went down and gets exhausted easily. Also developed aching pains in extremities. Condition gets worse with the time, hampering her daily activities. Along with these, she also developed sensitivity to cold, hair fall, and body weight started fluctuating. Patient consulted to conventional physician, were diagnosed as Hashimoto's thyroiditis, and started treatment accordingly. From last 2 years, started suffering from hemicranial pains in either side. Gradually, frequency and intensity of episodes got increased. Again, consulted to conventional physician, were diagnosed as migraine without aura, and treated accordingly. But not much relief was obtained. Because of the pains and easy exhaustion, gradually patient became irritable and indifferent, do not like to talk much, or answers indifferently whenever asked anything, avoids much physical activities, including her household work, do not like to go out or meeting people, etc. Theranom started initially with 25 microgram dose, gradually raised to 100 micrograms without any significant relief. Now, patient decided to undergo for homeopathic treatment. Physical generals considered were patient was chilly, desire for cold water and cold drinks, difficulty in falling asleep and awake unrefreshed. Menstrual history, nothing specific. Mental generals considered were irritability from contradiction, indifferent to everything, and concentration difficult. Past history of leukorrhea, for which took conventional treatment. Family history, father was having vitiligo. Mother and elder sister were also suffering from hypothyroidism and migraine and under conventional treatment. Physical examination, body weight was 54 kg. Thyroid gland was mildly enlarged, soft and movable. Dryness of skin was there and hands and feet were cold to touch. This is the thyroid profile. At the time of consultation, TSH level was 12.27 micro international unit per ml. Antithyroid peroxidase antibodies test, a diagnostic test for Hashimoto's thyroiditis. Level more than 60 international unit per ml is considered positive for the disease. Whereas here it was more than 1300 even after 2 years of conventional treatment. FNAC of thyroid gland also confirming Hashimoto's thyroiditis. CT scan of the head done for hemicranial pains was normal. Meadows scale or migraine disability assessment scale was used here. It is a 7-questionnaire scale helped to assess impact of migraine on patient's life in terms of limiting their activities at workplace, household, and social activities in past 3 months. It also helps to assess number of days patient was suffering with headache in past 3 months and pain intensity. The scale was used initially to set the baseline and then repeated at 3-month interval to assess the treatment response. At baseline, Meadows score was 10, reflecting grade 2 disability with 15 days headache in past 3 months, and pain intensity varies between 3 to 8. To interpret the pain intensity, most by pain rating scale was used, which is also known as Wong-Baker face pain rating scale. Now, symptoms considered for the case: irritability from contradiction, indifferent to everything, chilly patient, desire cold drinks or cold water, weakness from exertion, weight variable, difficulty in falling asleep, dryness of skin, aching pains in extremities, coldness of hands, coldness of feet, heat feeling in soles at night, headache worse in morning after rising from sleep, hair fall, and Hashimoto's thyroiditis. The case was repertorized with radar 10.5 software. After repertorization, thyroidinum was selected for the case, considering that the case was full of common symptoms of the disease and lacking patient's individuality. And thyroidinum being one of the most common medicine for thyroid disorders coming into the picture and is the only medicine covering complete repertorial totality. So thyroidinum was prescribed in medium potency, 30C, repeated twice a day for 2 weeks. On 14th October, pain extremity is better, headache, 1 episode in between, nausea better, otherwise not much change in the condition was there. So same prescription was repeated for another 2 weeks. On 31st October, condition better in general, so repetition reduced to once daily and continued for 1 month. On 8th December, condition improved further, irritability much reduced, now sleeps without any problem, headache 3 episodes in between with reduced intensity and no nausea was there. Some changes in mental and emotional ground were also observed. Now she was doing her household work happily, does not like to be alone or likes to be in company, enjoying going out, meeting people, became more emotional, weeps easily and relaxes when sympathized. Body weight was 53.4 kg at this stage. TSH also improved to 10.47. Thyroid gland was also slightly better. So when the condition is improving satisfactorily, patient was put upon Rubram. On 7 January, condition status quo. and also complaining of leukorrhea from past 10 days. MIDOS score was 8, with 12 days headache in past 3 months, and pain intensity varies between 3 to 6. So potency was raised to 200, single dose PET was given, followed by Rubram. On 24 January, pain extremities slightly more than before. Leukorrhea continued, headache 2 episodes with more intensity than previous episodes. Also complaining of low thirst nowadays. So even after raising the potency, when no positive change was observed in the condition, rather symptoms were taking reverse direction. The case was reassessed and re-repertorized. The case was again repertorized, including the new symptoms like company desire for, weeping easily, consolation amelioration, thirstlessness, and leukorrhea blend, and some relieved symptoms like irritability from contradiction, indifference, and sleep disturb were removed from the totality. And now with this new totality, pulsatilla is on the top of the table and was considered because it's covering the patient as most. So on 24th January, pulsatilla in 200 potency C, single dose was given, followed by Rubram for 2 weeks. On 9 February, condition better in general, so Rubram was given for another 1 month. On 15 March, pain extremities and leukorrhea was slightly more. Headache 2 episode in between with reduced intensity. So potency was raised to 1M, single dose was given. On 20th April, condition much better in general. TSH came down to 5.27. Anti-TPO also reduced to 722. MIDOS score at this stage was 5, with 7 days headache in past 3 months and pain intensity between 2 to 6. Rubram continued. On 19 May, patient complaining of again pain extremities with two episodes of headache in past 3 2 episodes of headache in between with slightly more intensity. So potency again raised to 10M, single dose was given, followed by Rubram for 1 month. On 26 June, condition much better in general, so Rubram continued. On 31st July, condition continued much better, and MIDOS score at this stage was 2, with 4 days headache in past 3 months, and pain intensity varies between 2 to 5. So Rubram continued for another 1 month. On 5th September, condition asymptomatic, Rubram continued. On 12th October, condition asymptomatic, and TSH level at this stage was 3.25 within normal limits. Anti-TPO was 58.6 within normal limit, considered as negative for Hashimoto's thyroiditis. On examination, thyroid gland was not palpable, so Rubram was continued for another 1 month. On 16 November, condition continued asymptomatic, and MIDOS score at this stage was 0. So when laboratory investigations were within normal limits and patient was remained asymptomatic for nearly 3 months on ethical ground, patient was advised to stop the treatment and report if any problem reoccurs. This is the thyroid profile at a glance. Anti-TPO at a glance. At baseline, it was more than 1300, which reduced to 722 on 24th April and was normal on 12th October 2019. This is the MIDOS scale at a glance. Now, in discussion, like other autoimmune diseases, Hashimoto's thyroiditis 2 is a challenging disease. The case becomes more challenging when associated with migraine. The case was in different layers. Initially, common symptoms of the disease, masking the individuality of the patient. Initially, thyroidinum was prescribed, which clears the superficial layer and brings patient individual symptoms on the surface. And later, pulsatilla nigricans was prescribed, which brought complete restoration of health. With nearly 1 year of homeopathic treatment, the patient became completely asymptomatic, and lab investigations also came down within normal limits. Monarch score was +7, indicating likelihood of causal attribution between homeopathic intervention and clinical outcome. Conclusion. The outcome of the present evidence-based case report is encouraging showing efficacy of the individualized homeopathic medicine in enhancing or stimulating body's immune system, that is, self-regulatory mechanisms over the particular or pathological and diagnosis basis. However, more case studies with large sample size are required in this area to validate the outcome. Patient's consent was taken and efforts were made not to reveal her identity here. Financial support was nil and no conflict of interest was there. Thank you so much.
Thank you, Dr. Garyani. Indeed, a nice presentation. The chairpersons, kindly ask the questions that you have for Dr. Garyani.
Thank you very much for an interesting presentation, which was of personal interest to me because one of my daughters was diagnosed with Hashimoto's thyroiditis when she was young. So I followed this with great interest. And I was wondering, first of all, why you selected this specific case, whether you treated the rest of the family, and whether you have followed up your own advice by documenting other case reports of this condition.
Actually, in my clinical practice, in my clinic, patient randomly approached with me, and it was a very interesting case because in modern science, it was there's a lot of limitation for this. Already, she was taking conventional medicine for 2 years. Even after that, the levels were very high, and she was disappointed and tried to consult the homeopathy now. And in homeopathy, we take the totality of the patient and treat according to that. So it is a chance to see the scope, whether we have really scope for that or not, or we are also for the symptomatic coverage only.
And did you treat the rest of the family? Because she was not the only member with this problem.
No, ma'am. I already told that her mother and her sister, which is also suffering with hypothyroidism and migraine, were under conventional treatment.
They didn't come to you?
Up to not now, and immediately after this patient, even this pandemic was started, so everybody is restricted. Everybody's life is restricted now.
Right. Okay.
Thank you, ma'am. So let us move to the next presenter. I invite Dr. Hitesh Purohit. He will be presenting his case report on living materia medica, perceiving image of the Ophidia remedy. Dr. Hitesh, you can kindly start sharing your screen and present.
Yeah, I understand.
Thank you, sir.
Yeah, so what is the more important aspect of I will try to focus on sphere of action of Sankarids, pathogenesis, and will try to understand the important parameters of Sankarids from the cases, and then we'll go to the source book. But before that, I would like to have what exactly we mean by the living materia medica. Because when we talk of a living materia medica, we mean that we have to observe life and living of the patient, and that in life and living, what Hahnemann has said is the portrait of disease, and that is the aphorism 6. Because in books, what is available to us is from the years it's been a proved remedy, and when we talk of a Sankarids, it is a partially proved remedy. So what we will try in a series of a case study, which is I'm going to present, where establish similarity of our patient, and we'll see how it is reflected in the materia medica. My first case of a Graves' disease, where the environment, which was very, very important to understand. The father was a don, and everybody had a fear, and patient imbibed the values of the father. Patient imbibed the identification, and then we were able to see the aggressions, maliciousness, suspiciousness, and fear, characteristic fear, anxiety about the health and family member. And as he was grown up, there was a certain allegation was put forward. We were able to see the expression in the form of anger, trembling of the body, abusiveness, breaking them, violent and slapping. Characteristics, dreams were available, and at the physical level, we were able to see the patient was absolutely chilly, with certain cravings, and perspiration will have a profuse perspiration, menses which is characteristic in form of staining and clotted. In the work, she was absolutely perfect, and patient used to aggravate with a contradiction and teasing. We'll go to the case 2, which is of a primary hypothyroidism, where we were able to see the father put allegations on a mother as a prostitute, and father used to beat. And that is a very, very important aspect of understanding the case, why an individual develop a certain qualified mental. So in that patient also, the aggression was available. Patient was extremely irritable, and the two important aspects which I would like to focus in this case was the anxiety and sensitivity, which was a very, very important. The expressions were available at the level of oral, abusive, throwing things, violent, and injustice to the mother, which she was not able to tolerate, with a characteristics dreams of a dead body, ghost, etc. And while at the physical, again, we were able to see the offensiveness of all the discharges with indelible brown stain and coffee-like menses, with sun used to aggravate the headache. And at the work, she was again a perfectionist. She used to be, complaint used to be aggravated whenever there was a false allegation has been done. Case was reportized, and we were able to see the Ophidia group of remedy which is coming up. Case number 3. Now, in earlier 2 cases, we were able to see the discord between the father and mother. Now, in this case, she was a student of a modern medicine, MD, and there was a strong religious background. And another important thing was the father wanted a male child. So that has produced a forsaken and insecurity. And since early childhood, she was exposed to the sexual relationship, which she saw when she was almost 5 years old. And that has brought the tremendous aggression within, insecurity, the forsaken feeling, and competitiveness. The expression which were available in the form of masturbation, revenge, outspoken rebelliousness, with a fear which is coming prominently, and that sensitivity to injustice and critique. At the level of work, she was excellent, and complaint used to aggravate when there was a insecurity. While at the level of physical, we were able to see the sun, which aggravate the headache. There was offensiveness of perspiration and staining of the perspiration, while the menses have a brownish green, indelible. This was a case where religious background played a role, major role. As we are moving to the case, again, repertorization was done, and Ophidia group has come predominantly. Another important case where diagnosis was a right neurogenic thoracic outlet syndrome. Father was a priest, absolutely a religious background. And in that religious background, we were able to see the child who is growing up and developing a tremendous aggression, because there has to be a suppressed number of things. And with a high sexual desire, as she grown up, we were able to see the expression of aggression in a way of violent, beating, quarrels, impulsivity, and multiple sexual relations, with addictions of a smoking and drinking, with characteristics dream of a fright and a sexual relation with a girl. At the level of physicals, we were able to see the sun used to aggravate the anger, perspiration was profuse, and craving for shower and other things. And again, when we repertorize, we were able to see the nuts and Ophidia group come very prominently. A number 5th case, where it's a case of conversion disorder. The girl who has come and seen the restriction of father, tremendous restriction of a father, not able to go out, not able to do what she wanted to do. The environment play a major role, and that has led to the aggression, that has led to the tremendous anxiety within her and sensitivity. And there was a direct relationship of this aggression with abdominal pain. And that pain has been not better by any treatment. Then she came to us, and we see the another way of expression of anger was a violence and throwing the thing. Fear was also a predominant. At work, she was fastidious, and the complaint used to aggravate by suppression of anger and scolding. The dreams have a peculiar way, and dreams of accidents, quarrels, murder of self, and gore. We are able to see how much subconscious was playing a role. And at the physical level, patient was absolutely chilly. Sun used to aggravate the headache, craving for shower, and menses, which is having clotted, staining, and indelible. Now, what we are able to see in all the 5 cases, case number 1, 2, and 5, we were able to see the parental conflict, disturbed childhood. There was a allegations were put on the mother or on a patient that has led to the evolution of a aggression and sensitivity both. While in case number 3 and 4, we were able to see there was a strong religious ethical background. So another important thing, the id was not satisfied in case number 3 of a love, care, that 4-second feeling was there, and which has led to development of insecurity, and religious background played a some or a major role in development of a high sexual drive. So as we are going further and trying to compare all 5 cases, the
Excuse me, sir. Sir, could you please wind up in next 30 seconds, sir? Sorry.
okay, we were able to see the aggression through and through. We are able to see the expression which are coming up, and we were able to see the abdominal pain. Fears, peculiar fears were available with anxiety at a various level and dreams. As we go further and try to compare now what is available in the cases and what is available in materia medica. Aggressions, insecurity, forsaken, and high libido was a core emotions. The various expressions were available, and when we go to the materia medica, we were able to see the irritability, anxiety, forsaken, betrayal, hate, revenge, explosive, and sexual expressive. And expressions were available in the form of sensitivity and various horrible dreams. There are a comparison of the cases at the physical level also. We were able to see the number of things which come very nearer when we read to the homeopathic materia medica and the available books. The sphere of action, there was an involvement of a glands to the nerve, while the disease, we were able to see the grave disease to the neurogenic thoracic outlet syndrome. Pathogenesis, we were able to find out the spasm to the compression. In materia medica, when we read, we have a number of illnesses which are reflected in the cases of Sankris. In final conclusion, what I would like to see, the way various tissue, organ, and system are involved with different type of pathogenesis leading to functional and structural degenerative changes, and various clinical diagnoses give us an idea of range of diseases covered by Sankris contouring. And learning from various cases and going to source book and commentaries on materia medica give an insight to understand homeopathy materia medica in a better way. Hence, we can say Sankris can be one of the important remedy of Ophidia group. Thank you, Liga, for giving me an opportunity to share my experience related to Sankris. Thank you, my patients. Thanks to my teacher, and thanks Dr. Jawarsa for giving me the platform. Thank you all.
Thank you so much, sir. Now I would directly go to Dr. Dikshit. I think she's ready now with her presentation.
I would just like to make an announcement. Dr. Dilip Nanda, we have promoted you to panelist. Please accept that. Because I think, okay, we've got
Yes,
Hello all, am I audible?
Yes, ma'am. Now you are.
Okay, my slide is visible?
Yes, you can start, please. And
Okay.
please, my sincere request, please adhere to the timing.
Yeah. Sure.
Okay, thank you.
My topic is to understand the role of homeopathy in the epilepsy in the pediatric age group. The plan of presentation focus about the prevalence, common cause in the children, case series, common observation, understanding the role of homeopathy, and the final conclusion. Epilepsy is a chronic disorder that causes unprovoked recurrent seizures. The seizure is the main symptoms. It is the second most common and the frequently encountered neurological condition. 50 to 70 million of people have the epilepsy. From that, 10 to 12 million of people who reside in the India. So from the research study, they find out there is a more commonly find out in the underdeveloped country and in the rural area. Now the common causes of the epilepsy in the children, these are the fever, genetic causes, head injury, infection of the brain, lack of oxygen of the brain, hydrocephalus, and the disorder of the brain development. Epilepsy can affect the many other aspects of the child's life, deteriorate the clinical state, affects motor and the intellectual functioning, complicate the rehabilitation, and sometimes it is a life-threatening. I am working at the Umid Cerebral Palsy Center at the Kurjan. We observe there is a changes in the children with epilepsy after the homeopathic intervention. We could find out there is a reduction in the intensity and the frequency of the epilepsy with the development of the mental and the physical. This is the case 1. I am not go into the detail about the how the materia medica part of there is a repertorization and everything. I would like to more focus how the homeopathy help to improve the clinical state of the person. So this is the child which we received at the age of 3.5, diagnosed as a cryptogenic epilepsy, where we can find out there is a mild AD and the autism, and the keynote there is a typical behavior pattern. There is a cranky child, so parents are frustrated related to the disease condition as well as the behavioral problem. From the January 2017, we started the remedy, the SINA as a depicting force. So we last episode identified in the April 2017. After that, the anti-epileptic drug stopped by the pediatrician in the 2018. So within a 3 month of the span, we identified there is a definite registration is developed, and within 5 years of the experience and the treatment, now the patient is still continuing under our treatment. Now the autism score is 19 and the IQ is increased from 40 to 45. So they started the 200 1 packet weekly. Now it is a 1 and 3 packet weekly with the intercurrent. There is a IR as a tuberculinum, which is infrequently given. Now the case 2, diagnosed case, there is a Lennox-Gastaut syndrome. There is a multiple type of the seizures. There is a head drops. There is a generalized tonic seizures. The frequency of there is a 6 to 7 times per day. And the atonic seizures, there is a once per day. Also, after the development of these Lennox syndromes, there is a regression of the milestones. So now the patient is feeling of the hopeless because the child is 8 years old. They are not thought from the second child because they find out there is a brain malformation and the anti-epileptic drug as gradually increase as per the age. The treatment started in the August 2010. The final remedy we concluded there is a phosphorus. So within a 1 year, the patient is under our treatment, but within a 1 year of the span, we could identify there is a definite improvement at not only the epilepsy level, but the now child is able to stand up without support for the 50 minutes. And definitely there is improvement at the weight where there is a 3 kg, which already suffered from the malnutrition, and the speech is also started. So definitely we can identify there is a phosphorus 33 packet weekly which started, which now there is a 33 pills daily TDS, which there is a use of the infrequent use of the intercurrent remedy. Now the case 3, the quadriplegic CP children. These children is also having there is a 2 type of the seizures. There is a jerks and there is a generalized clonic seizures. So jerks which 15 to 20 times per day, and the seizures, the generalized clonic seizures which 0 to 4 times per day, which remains the 50 minutes. Also, we identify this associated state, there is a bedridden child. The child, because of there is a bedridden child, the parents are suffering even with this clinical state. There is a not responded with the multiple therapies, even they also go on with the keto diet. So they are frustrated with the multiple therapies, which we can find out there is a MRIs, periventricular leukomalacia and the abnormal EEG. The typical presentation, we find out there is a continuous nodding of the head during the case taking. So after the case taking, we concluded there is a netramule, which is a depicting force. We started 0 by 1, 3 packet weekly, which considering there is a pathological changes. Within a 2 year, All the patient are continuing till now. So within a 2 year of the span from September 2019 to November 21, so there is a definite improvement in the myoclonic jerks. Now the generalized seizure, which only the once per week, preictal symptoms is absent, drooling is absent, and now the speech is also started. So which providing there is some hope in the parents. So there is a frustration and anxiety is reduced. Nitramur, which started 0/1 3 packet to there is a 0/3. 3 pills daily TDS, frequently use the intercurrent as a TUB once per week since last 1 year. Now the case 4, there is a 13 years old girl which received the February 2017 the focal epilepsy. After there is a brain TB at the 8 year of the age, there is a brain TB. Afterward, there is a development of the focal epilepsy. Consequently, there is a right side hemiplegia. Also, there is a delayed puberty. So we take the opinion of the pediatrician and the gynecologist for the delayed puberty. They suggest the investigation for the confirmation of the diagnosis. But the parents are anxiety about the health. Because of these two clinical conditions, the scholastic performance definitely reduced. So they have anxious about the disease state, the study of the child, as well as there is a social stigma as epilepsy in the girl. We could identify there is some characteristic symptoms. So from that, we have to finalize the remedy as a phosphorus. So within a 3 month of the span from February to April, there is a secondary sexual characteristic is developed and the reduction in the intensity of the frequency of the seizures, but the hemiplegia remains acute. Now we see further in the follow-up, the patient is still under our treatment. So within a 4 year of the span, there is a last episode which come in the 2019. She has secured the second rank in the 8th standard. So definitely there is improvement in the scholastic performance. The right limb tone and power is little bit improved. They are not regularly coming for the physiotherapy at our center. The anti-epileptic drugs which remains as a same, the last age in 2021 January, which is abnormal. Started the phosphorus 33 packet to now at present going there is a 203 packet weekly, and the intercurrent as a basilinum which is given there is a infrequently. Now the case 5, there is a 15 years old girl having the primary generalized tonic-clonic epilepsy. The complaint started at the 5 years of the age. But since 1 year, there is a frequency is increased. So the parents has become anxious about because they are regularly taking the follow-up to the pediatrician and going the anti-epileptic drugs. We identify the characteristic symptoms pre-ictal, ictal, and the post-ictal. And from that, we have to finalize the remedy as a calcarea carb. We have started the calcarea carb 33 packet HS weekly. So see, there is a patient is taking treatment since long as a 5 years. The last seizure episode which came in the June 2018 for the just 2 minutes. The January 2018, they stopped the medication by self without our information in the instruction. The calcarea carb 33 packet HS weekly, which continue. Now we reach to the higher potency. There is a 1M 3 packet weekly. The intercurrent 1M to 10M tube is infrequently used. Now the observation of these cases, we identify there is a susceptibility lower to moderate zone, sensitivity which is moderate to higher zone. I would like to more focus, there is even with the pathological
Dr. Dixit, I'm sorry to interrupt. Could you please wind up in the next 1 minute?
Okay, ma'am.
Thank you.
So there is a predominant miasm which is a tubercular. So now we can identify there is a definite role of the homeopathic medicine. Homeopathy helped modify the quality of life, reduce the intensity frequency, facilitate the development. In the structural cases, also the role of homeopathy we could identify, which help to taper and stop the anti-epileptic drugs. The focus, there is a structural cases which require low potency with the frequent repetition, functional which need moderate to high but the frequent repetition, intercurrent which is also depends on the case base. Acute remedy, related to the acute remedy, the case is not presented, but it is also definite the role in some cases. So at the last, there is homeopathy treating the epileptic patient, not focus only the epilepsy. So the follow-up assessed on the basis of the frequency of the seizures and decide the dose on the development of all the aspects. So I concluded this understanding about the 5 case series, and with the experience of the ample of cases of the epilepsy, I select my PhD research topic to study the if action of the homeopathic remedy on the epilepsy cases to find out the change in the clinical presentation as well as then the EEG. Thank you to all. First of all, there is LMHI team who provide this platform, the Leopold Foundation Germany, Srimati Malini Kishore Sangvi Hospital, as well as the HOD guide who provided the best learning in our center, Dr. Hema Parikh and the Dr. Jawaharlal Sir. Thank you to all.
Thank you, ma'am. Thank you, Dr. Dikshit. And now we come to the end of this session. This was indeed an enlightening session, although we had a little time constraints here and there. Now I would request my chairpersons to please conclude the session. Dr. Fibbert and Dr. Sharma, please give the concluding remarks.
Hello. This whole session was very, you can say, in the scientific term, we can say that purely scientific, because all the presenters having a good analysis of the cases. In this last case, that is regarding the epilepsy. So we can conclude that the totality, which is the base for our prescription, is the key for the success, that is for the treatment. And moreover, as she has narrated that she has taken a good result with the polycrest, and no doubt the acute remedy have a role, but polycrest having the upper hand in the treatment of such cases which are having some background of the miasmatic structure. And in the last case that we have seen with Dr. Hitesh, he has presented a good case regarding the centuries. And in this, we know that in all of India, especially the centuries, which is also called as the copperhead snake, in that particular, the most of the predominance is with the lachesis symptom. That is, it is again a left-sided remedy. And moreover, he has proved that in this remedy, that is the forsaken sensation or the forsaken feeling as well as insecurity, which predominates in the whole of the remedy. So thankful to Dr. Hitesh. Then in the previous to this, Dr. Nishant, he has taken a case of this thyroiditis with migraine. In that case is also. So I have one question with Dr. Nishant, that when he firstly reportized the case, the first remedy was the phosphorus. And when second time he reportized the case, again the pulsatilla and phosphorus was again on the top. But in first cases, he has started the thyroidinum, that is again with the 30 potency, not with the trituration. And most of the people in such cases tried with the trituration. But as a rare experience, the centesimal scale also having a upper hand. And in last, the pulsatilla has given a relief to the patient, which is again a marvelous. So with this, I can conclude that all the topics which were covered in this particular sessions were very precious and having a practical utility. Thank you.
I would just like to add to this very thorough conclusion my brief comments on the design of the different presentations, because we saw a real variety from a single case study through case series through to some more systematic research. And I think what this series has shown us is the importance of every different type of research. So we start with our individual case studies, and then we start to collect them together. Then we move on to doing more systematic research with randomization and comparison. And at each stage, we learn from the stage before us. And I'm just very excited to see that there is so much research going on of all these different types, which can lead eventually to much better promotion of homeopathy and explanation of how it works, because the efficacy studies are really beginning to show this. So I would like to congratulate all the presenters and wish them the very best going forwards to develop these observational and case series into more systematic research in the future.
Thank you so much, ma'am. Thank you for your valuable inputs. Mr. Hime, I hope you've taken the screenshot of the whole group.
Sure, I'm taking the screenshot right now. So I just request one or two doctors have not turned on their camera videos. Could you just please switch on your videos? And everybody, let's smile, and I'm taking the picture. 3, 2, 1. Okay. Lovely. We are done. Thank you. Thank you.
Thank you so much. I take this opportunity to thank our chairpersons, our moderator, Dr. Nirmal, and the coordinators, Dr. Ritika and Dr. Radhika, Mr. Hime and his team, and all the presenters for a wonderful presentation. Thank you all so much. Thank you.
Thank you so much, ladies and gentlemen, for being on this virtual dais. It was a pleasure having you all here, and we conclude the session out here. Thank you very much for staying with us. Thank you, everybody.
Thank you.
Thank you.
Namaskar.
Namaskar. Jai Hind, Jai Bharat.